Hi everybody, welcome to my YouTube channel Dr.Sreenivas Medical Concepts and my FB page Dr.Sreenivas Concepts. This is Dr. Sreenivas, neurologist from Rajahmundry, Andhra Pradesh, India. My email is 3klpm@gmail.com. I'm also the medical author of the two books Focused Neurology and Exam Oriented Clinical Neurology. We are continuing with a series of lectures of Prime Neurology. There are going to be 50 episodes of Prime Neurology, and if one listens to all these 50 episodes of Prime Neurology, they would have acquired a good knowledge of neurology. Right now we are on Prime Neurology Part 15, Spinal Cord Disorders Part 2, Localization. The localization of lesion at each spinal cord level. So we'll go step by step: cervical, thoracic, lumbar and sacral. At the level of the cervical cord, upper cervical cord lesions produce quadriplegia and weakness of the diaphragm. The uppermost level of weakness and reflex loss with the lesions are at C5, C6, biceps jerk is lost. C7, triceps, fingers and wrist extension are affected. C8, finger and wrist flexion are affected. But lesion at any level of the cervical cord can produce Horner's syndrome, that is meiosis, ptosis and facial hypohidrosis because of the involvement of sympathetic tract. Now let's talk about the thoracic cord. Lesions here are localized by the sensory level on the trunk and, if present, by the site of midline back pain. The useful markers of the sensory level on the trunk are T4 corresponds to nipples and T10 corresponds to umbilicus. There is an important sign known as Beaver's sign when we try to localize the lesion at thoracic cord. What is Beaver's sign? Lesions at T10 level paralyze the lower but not the upper abdominal muscles, resulting in an upward movement of the umbilicus when the abdominal wall contracts. Lumbar cord, L2, L4 and L5, S1. So what happens when there is a lesion at L2, L4 level? It paralyzes flexion and adduction of the thigh, weakens leg extension at the knee, and the deep tendon jerk which gets affected is the patellar reflex. So it abolishes the patellar reflex. L5, S1. It paralyzes the movements of the foot and ankle, flexion of the knee and extension of the thigh. It abolishes the ankle jerk, S1, S2. Sacral cord. There are two important concepts here: conus medullaris and cauda equina. So what is conus medullaris? Conus medullaris is the tapered caudal termination of the spinal cord comprising the sacral and single coccygeal segment. The conus syndrome consists of bilateral saddle anesthesia because S3, S4, S5 are affected. There is a prominent bladder and bowel dysfunction, that is urinary retention and incontinence with a lax anal tone and impotence. The bulbocavernous reflex, that is S2, S3, S4 and the anal reflex S4, S5 reflexes are lost, but muscle strength is largely preserved. What is cauda equina? Cauda equina, from the Latin word horse's tail, is a bundle of spinal nerves and spinal rootlets consisting of 2nd through 5th lumbar nerve pairs, the 1st through 5th sacral nerve pairs and the coccygeal nerve, all of which arise from the lumbar enlargement and the conus medullaris of the spinal cord. So what happens when there is a lesion of cauda equina? They are characterized by low back and radicular pain, asymmetric leg weakness and sensory loss, variable areflexia in the lower extremities and relative sparing of bowel and bladder function. Note: mass lesions in the lower spinal canal often produce a mixed clinical picture with the elements of cauda equina and conus medullaris syndrome. So what are all the differences between the conus medullaris and cauda equina? So we can talk about the differences with 6 points. Point about spontaneous pain, the sensory deficit, the motor loss, reflex loss, bladder rectal sexual symptoms and onset. Spontaneous pain. Spontaneous pain in conus medullaris, it is not common or severe but bilateral and symmetrical in perineum or thighs. Cauda equina is basically nerve roots. So maybe most prominent symptoms, severe radicular in type, unilateral or asymmetric. Always remember lumbar disc prolapse when we talk of cauda equina, because it is one of the common causes of cauda equina, lumbar disc prolapse. So when there is a lumbar disc prolapse, there is a severe radicular pain, unilateral or asymmetrical. Sensory deficit. So conus medullaris means we are talking about the tip of the spinal cord. So S3, S4, S5 are primarily involved. So there is saddle distribution. Bilateral usually symmetric. There can be dissociation of sensation. That means spinothalamic tract being affected. So pain and temperature are lost as compared to the position joint vibration sense carried by posterior column. Since the pain fibers are affected, there can be decubitus. Whereas in cauda equina, there is saddle distribution, maybe unilateral and asymmetric. All forms are affected. There is no dissociation of sensation and decubitus are less common. When it comes to the motor loss, it is conus medullaris is symmetric, not marked, and fasciculations may be present because anterior horn cell may get affected. Whereas in cauda equina, it is asymmetric. It's only roots. More marked, atrophy may occur, but usually no fasciculations. Reflex loss. Since the lesion is at the level of the conus and epiconus, that means S1, S2, S3, only ankle reflex, that is Achilles reflex, is lost. But whereas cauda equina, since the lumbar roots are also affected, there is both patellar and Achilles reflexes which may be absent. Bladder rectal and sexual symptoms early and marked in conus medullaris, late and less marked in cauda equina. Onset, conus medullaris, it is sudden in onset and usually bilateral, whereas in cauda equina it is gradual and unilateral. So these are all the important differences between the conus medullaris and cauda equina. The other clinical aspects of neurology, I put it in a book called Exam Oriented Clinical Neurology, written by me, Dr. Sreenivas, published by White Army. This contains all the essential clinical points of neurology. So this book will be very useful for students appearing for clinical neurology exams, and if interested, this book could be purchased. The other book I've written is Focused Neurology, written by me, Dr. Sreenivas, published by CBS Publishers and Distributors. This contains all the essential theoretical aspects of neurology put in a question and answer format. This book is available from online from all leading booksellers including Amazon. So if interested, this book could be purchased online. As I said earlier in this in the lecture, there are going to be 50 episodes of Prime Neurology, and if one listens to all these 50 episodes of Prime Neurology, one would acquire a good knowledge of neurology. If you have enjoyed listening to these concepts, please like, share the link, but please subscribe to my YouTube channel, Dr. Sreenivas Medical Concepts, which is India's leading neurology educational YouTube channel, and my FB page, Dr. Sreenivas Concepts. Thank you. Bye.